The subject is a 21-year-old female middle-distance track athlete with no current injuries. Her previous injury history includes low back pain and a torn hip labrum. From the anterior view, the most obvious compensation is the athlete's knees moving inwards, particularly the left side. Both feet are turned out, with the right foot becoming more externally rotated with increasing repetitions, indicating overactivity of the lateral gastroc, soleus, biceps femoris, TFL, and adductors. From a lateral view, overactivity of the hip flexors and lats and underactivity of the glutes and core allows for significant arching of the back and a slight forward lean. Again, overactivity of the lats with possible pec complex results in the arms falling forward. Posteriorly, the compensations at the feet become more clear. The right foot turns out with more, while the left appears to flatten more. There is an asymmetrical shift to the left with greater left knee adduction. The left arm is more anteriorly displaced. In the modified overhead squat with the heels elevated, her squat improves significantly with minimal inward knee motion. The left arm remains more anteriorly displaced. The shift to the left, although not as pronounced, is still evident, and the left foot still tends to flatten. Therefore, it is clear that the foot and ankle complex plays a significant role in this athlete's compensation. However, the influence of the overactive lat, TFL, and adductors, as well as underactive glute complex, still cannot be ignored. On the right leg, the knee moves in with reduced neuromuscular control. The left hip drops and the right foot externally rotates more. There is clear inward rotation of the trunk toward the stance leg. The left hip drop can be clearly seen here, indicating overactivity of the left adductors and underactivity of the left glute med. As the knee moves inward, the trunk leans and rotates to the right side, again implicating overactivity of the tensor fasciae lata, adductors, and underactivity of the glute complex. The inward knee motion is more pronounced on the left side with loss of neuromuscular control. The left foot is not as externally rotated as the right, but there is flattening of the arch, indicating a tight lateral gastroc, soleus, biceps femoris, TFL, and underactivity of the glute complex, medial hamstring, and gastroc. Underactivity of the glute complex and overactivity of the TFL and adductor in particular is clearly visible with increased valgus angle at the knee, a slight hip drop, and some inward rotation to the stance leg. Linking all the compensations together then, the foot and ankle complex play a significant role in her movement dysfunction, as evidenced from the modified overhead squat, with overactivity of the lateral gastroc, soleus, biceps femoris, and tensor fasciae lata, and underactivity of the medial gastroc, hamstrings, glute medius, and glute maximus, which result in the feet flattening out and rotating outwards. The most obvious compensation pattern is the inward knee motion. The overactivity of the adductors, TFL, in particular on the left side, and the underactivity of the glute complex contribute primarily to this and are also responsible for the left asymmetric shift. The overactivity of the lats, especially the left side, is an important contributor to her impairments, contributing to the arching of the back and the arms falling forward. The lumbopelvic hip complex and core musculature play a dominant role, with underactivity of the glute complex and core muscles evident in the valgus knee angle created, the hip drop, and the trunk motion on the single leg squat. Her previous injuries of low back pain is not surprising with the increased lordosis of the spine. The increased foot pronation and the internal rotation and adduction of the femur places increased stress in the hip joint, affecting the orientation of the femoral head on the labrum, and certainly provides insight into her torn labrum injury.